Hello and welcome to this session of the Enhancing Clinical Practices and Outcome stream of the SNOMED CT Expo 2021. My name is Susie Roy and I'm the Customer Relations Manager for the Americas and Collaboration Specialist at SNOMED International, and I will be moderating this session. Please use your Q&A in your AirTouch device to type your questions to the presenter, and all questions will be answered at the conclusion of the presentation. So now I'm very pleased to introduce Dr. Esa-Matti Tolppanen from the Finnish Institute for Health and Welfare, who will be presenting Finnish National Reference for Pathologic Anatomic Diagnosis, Migration from SNOMED 2 to SNOMED CT. Dr. Tolppanen, please proceed.
Thank you. Hello, my name is Esa-Matti Tolppanen, and I will, together with Dr. Paula Kujala and Mr. Härkönen, we will present you the Finnish National Reference for Anatomic Pathology. The project that started in 2018 and is in the final stages. Finland, you can see on the right corner, so we are the east-north corner, but no ice bears, and no penguins, as is a common misunderstanding. This is the outline for my presentation, and I'll start with the background. I have highlighted those points that I'm talking to you. It's easier for you to follow. Finland has been a member of the SNOMED community since November 2018. And the Finnish Institute for Health and Welfare, THL as we call it, acts as a national release center for SNOMED CT. In fact, SNOMED has been a traditional application here in anatomic pathology laboratories since early 1980s. That means SNOMED 2. And from the very beginning of this project, the pathologists promoted SNOMED CT as the platform for common terminology and coding. We set as our sort of core objectives that we want to achieve is to harmonize the terminology. That was the first thing. The terminology and coding. And at the same time, migrate to SNOMED CT as a platform. The other stakeholders saw several potential benefits from harmonization. And sort of self-evident is to enable search for pathology samples over laboratory boundaries, better quality for National Cancer Registry, and support for quality of care monitoring systems with standardized pathology diagnosis coding. And we also thought that as a prerequisite for to achieve harmonization, the first thing is to create commitment in the end result. And as means or ways to achieve the commitment, we were lucky to hire editor-in-chief pathologist who created confidence among pathologists. That is Dr. Paula Kujala. And we wanted to have an interactive process. I'll try to describe that with the pathologist, but also with the National Cancer Registry and the laboratory information system vendors. And also consensus among the pathologists in the definitions of concepts, or the reference set, if you like. Oops. Okay, about the project itself. the project was financed by the Finnish Institute for Health and Welfare. The steering group consisted of senior or chief pathologists in all the university hospitals. And as a demonstration of a commitment today, as it is, the university hospital laboratories finance the project. Okay, and then about a few words about the project itself. The first part, the first phase, was analysis of current practice, how the pathologic diagnoses are coded in all the university hospitals. We gathered data, 8.6 million reports, and we created a common database from the data. And then after the initial analysis, we started with one laboratory. The second phase, that's the Tampere University Hospital Laboratory, where editor-in-chief also came from. But the reason for selection was that Tampere has been, their coding has been sort of the original SNOMED 2. They have tried to maintain the coding structure first along the SNOMED 2 lines, but then later ICD-03, which, as you know, is, when looking at the morphology part, is very similar to SNOMED 2. And then moving to Turku, another university hospital, where we benchmarked the results from Tampere. And at this point, phase 3 in 2020, synchronization with ICD-03 and the WHO Blue Books. And this was a co-effort with the Finnish Cancer Registry, the pathologist in Cancer Registry. Together with Paula, they worked out a suitable subset and mapping between. Of course, there's a lot of help from the material that SNOMED International could provide us. The next phase 4, was iteration with thought leaders. We were lucky enough to get something like 40 to 50 pathologists who were willing to spend their time to provide feedback on their area of specialism. And together with the editor-in-chief pathologist, they worked out the subset that covers all the needs of the university hospitals. And the final phase, where we are just now, or entering just now, is the finishing and SNOMED CT authoring and publication. Okay, I just cover a few points in the process, few details only. Based on the discussion we had with the laboratory information system providers, we soon realized that we need a bridge identification for the concepts and for the terminology. Otherwise, the legacy laboratory information systems couldn't be used, or only after major rewrite parts of the reporting and searching functions, which rely heavily on the hierarchical code the diagnosis. The structure we came up with is, the first part is SNOMED 2-like concept code. You can also say that it's a ICD-03-like concept code for malignancies, malignant morphologies, followed by dash, and with SNOMED CT identifier. So the essential parts of the definition or the database, if you like to call it that way, looks like this. On the left, a column of legacy concept IDs, we call them legacy concept IDs, with the SNOMED 2 part or ICD-3 part in this case, and the SNOMED concept ID. And then the SNOMED concept ID, the SNOMED fully specified name. The next column is legacy term ID with the same structure. And then SNOMED CT identification for the description, and SNOMED CT term, that means our selection for a preferred term. And another point, just another point from the project itself, the iteration with thought leader pathologists, the professional authorities in their field. There were participants from all laboratories, 15 groups, each consisting of 2 to 5 pathologists. And the editor-in-chief pathologist curated the suggestions before uploading in the database. Some results or figures or facts. We found that having the actual coding frequencies, how many SNOMED 2-like codes were used during the 7 years, was very useful. Useful to focus on the right things, and also the analysis itself showed to the laboratories, if anyone was in doubt, that there's a lot of harmonization, so many differences between the laboratories. And we started with the pilot laboratory Tampere, as I said, which we saw that that was the purest SNOMED 2 stuff. And we were fairly successful in algorithmically mapping the codes used in the laboratory to SNOMED CT. And also the fact that this laboratory, when they had new definitions, new concepts in malignancies, they had copied the SNOMED 2-like code from ICD-03. That also helped. And then looking at the reference set itself, the number of SNOMED CT pathology, the Finnish version, the subset looks like this: body structure, 1,400 roughly, 1,500 morphologic abnormalities, and we can see that out of the morphologic abnormalities in SNOMED CT, the pathology version that the pathologists need was 1/4, every 4th. So quite many. While in the other concept categories like body structure disorders and so forth, very few concepts were included in the pathology subset. And then one of the results was an agreement between the university hospitals that how we should maintain this reference set in the future. It's always, in a sense, easy. It's not easy, but in a sense, it's easy to develop one version. But how to maintain it in the future? This is the plan. This is not what it is today. There are requests from the users, the laboratories, change requests. One laboratory that will be Tampere in the first phase at least will coordinate the effort, and the editor-in-chief will be the author using the pathologist network that we have set up, or the pathologist network come up with ideas, either following the WHO Blue Books or European Renal Association, whatever these professional associations who publish today delightfully often also tagged with SNOMED CT codes. But anyway, the contents is maintained in this gray box and delivered through THL, Laboratory Information System vendors, as part of the maintenance agreement, will maintain the list of available diagnosis codes. Okay, some lessons learned or discussion. The first thing is the positive things. It has been a pleasure to work within the SNOMED international community, and the services and especially documentation. I myself, who did the database management, used a lot of help from the team with template SQL scripts and so forth. That was very, sometimes even enjoyable, fun. And also one part of the international community is that the Swedish version of SNOMED CT is translated into Swedish, and that has been very helpful, very straightforward to apply in our case. So today we have a situation where the concepts are in English or in Swedish, but not in Finnish. That's part of the initial sort of strategy of SNOMED CT launch. More lessons learned where we could improve. The most important thing is the speed. This came up with the groups of pathologists, the specialist groups. This was a headache for the chief editor-in-chief pathologist. That there's discrepancies in the published, typically WHO disease-specific blue books compared to SNOMED CT. The shorter the time from the draft versions of Blue Book or accepted versions of the Blue Book to SNOMED CT concepts, the better. But also today, the non-neoplastic diseases, the not cancers, there's an increasing number of international professional organizations publishing sort of consensus agreement how we should classify, which concepts we should use. And also there should be a better synchronization between terminology. Otherwise it's a confusion in the field. The benign malignant hierarchy trees in SNOMED are not perfect in some places. They are very much out of reality. And perhaps the most annoying thing is might be even a conceptual discussion. It's not an easy chapter. ICD-03 is full of these discrepancies too. The distinction between disorders and morphologic abnormalities should be clear. It's easy to say, hard to implement. But there are too many cases where the morphologic abnormality is missing because the pathologist sees just morphologic abnormalities, and we have to rely on disorders, even sometimes in the category of findings. I have one example. It's a two separate things, the clinical diagnosis and that's disorder, where in SNOMED it consists of, as you know, of topography and morphology. There are relations to the relevant topography and morphology. But the morphology is in most of the case very sort of superficial, general terms, which is in most cases, that's enough for clinical diagnosis. But the pathologist sees and seeks the morphologic abnormalities, the morphologies. And if on the left corner, that's a clinician's view. On the right corner, it's the pathologist's view. But for instance, in this case, and there are several cases, it's not sufficient for neither use, the concept we have in SNOMED. So the diagnostic process in anatomic pathology laboratories is rapidly transforming into this digital age. This is a true picture from one laboratory. It's robotized, it's automated, it's digitized. But we are not that advanced in reporting the pathologic diagnosis so that the results could be used efficiently, because that requires broader consensus over laboratories, hopefully over national boundaries in the future. And this is an area where you cannot, anyone can expect overnight results. The final slide summarizing the presentation. Our core objective was to harmonize the pathologic diagnostic terminology as it was used traditionally, essentially topography, morphology, disease categories. And then from this basis, broaden the standardization in the future. Essential for success is commitment. The pathologists have to feel that it's their own classification. Means to achieve the goal, the commitment, and the harmonized, standardized terminology is to have an editor-in-chief pathologist. That has been very crucial. I have a feeling, I'm not a pathologist, that practically no pathologist would have done anything if there was not, if we didn't have the luck to have Paula to drive the definition process. Interactive process, increasing the commitment, interactive process with the National Cancer Registry, and also the laboratory information system vendors, who in the end are part of the process. Consensus seeking, not dictating, but trying to have a consensus between professionals. Implementation in the IT systems as painless as possible. We don't have any fancy functionality in the laboratory information systems to make use of the SNOMED CT wonderful system. They have to have a very simple coding too. And also the future maintenance system, so that we can adapt in a uniform way the national standards as they emerge. And we wanted to share our experience, how we did this, and what are some of the lessons we learned from pathologist view, and how SNOMED CT could be even better in the hands of pathologists. This completes my presentation, and I'll open my paper to discussion. Thank you.
Okay, thank you so much, Dr. Tolppanen, for your presentation. Can I please ask that all attendees just give us a moment while we switch over from our pre-recorded content so that Dr. Tolppanen can address all of the questions that you've been submitting live. Thank you.
Did I manage to?
Hi, thank you. So I'm going to jump right in because we don't have that much time for questions, and a number of them are coming in. So first from Nico. Oh, hi, Nico. Thank you for the presentation, Esa-Matti. It's a good example of how SNOMED 2 has been used regionally, but nowadays we need more interoperability terminology. What can you tell us about enthusiasm or reactions when you first started this project?
Well, talking about enthusiasm, if I understood correctly the question, I think Paula is the better person, as she is the pathologist.
Actually, we are surprised of how much we do have enthusiasm within pathologists and specialists, especially when we have been talking and discussing now with that 15 subspecialty groups. We get a huge amount of ideas that have not been fulfilled earlier. So yeah, yes, we do have enthusiasm.
That's great. That is great. From Dr. Jim Case, are the not otherwise specified codes used as part of the pathology reporting or for classification only? SNOMED tends to have more detailed morphologies that would otherwise be rolled up in classifications. Not otherwise specified is a classification-based term.
Well, I think Paula can complete my answer, but I think we are in the field of terminology. So those are the terms used in the response from the pathology lab. And that is one of the difficulties in the process, because we wanted to standardize also the terms used by the pathologist in their lab answers. But Paula can elaborate more about that?
Yeah, in Finland we use also in many labs in the reports directly this topography morphology, and that is in the form in the official SNOMED CT form, or earlier in this form like it is in WHO books. So some labs use Finnish, some use Swedish, but although the reports are in each language, this line of diagnosis is fairly strictly according to international terms. But of course the codes are not visible. They are there in the background of this system.
So one last little plug here from Stefan. In your example of urothelial carcinoma, the Cancer Synoptic Working Group at SNOMED International includes terminologies and pathologies that are hoping to close such of these sorts of gaps. We welcome other pathologists and others to join the working group to help with that work. So that extends to you, Dr. Tolppanen, and your working group, as well as to others who are attending this session. So I do see there are a few other questions in the box, but because we are running out of time and we all need to get over to the next session, I will wrap up. If you have any further questions for Dr. Tolppanen, please go ahead and send him your questions via the Q&A device. And otherwise, we will continue to speak with all of you during the SNOMED CT Expo. Thank you so much, Dr. Tolppanen, for your presentation, and thank you all for attending.
Thank you. Thank you for inviting us.